Hi, good evening, everybody. Welcome back to another session of webinar with Sunway. We are collaborating to give you one CPD point. And of course, Dr. Alexander Tan has been a recurrent speaker here with Beating Hearts. Previously, he spoke about diabetes. Today, he will speak about thyroid disease. Alex, hi, where are you? What's wrong with Alex? Can you guys hear me? Alex, Alex, we started, okay? We are live now.
Yeah, I know lah. Just want to make you panic a bit.
I won't panic one. I'm a very chill person. Almost
I
never.
don't bluff. Okay.
Okay, let's start.
Yeah, okay. So thank you very much, Betty, for inviting me again. So yeah, today talking about thyroid disease. But you know, the problem with thyroid disease is actually there's a lot lah. There's a lot. But I break it up into a few categories. So basically there's thyroid too much, hyperthyroidism, thyroid too little, hypothyroidism, and then thyroid growing things, which is basically your nodules, and then you can branch out to thyroid cancer, etc. But you know, it's all a bit too much lah for me to squeeze into one lecture. So I look back, and what I realized is that, these are my disclosures. Okay. I realized that back in July 2020,
I want to read
exactly.
the previous slide, please.
No, cannot. You are too slow. You are too slow
I just
already.
said I want to follow Dr. Betty.
Yeah. One Sri Betite, you're too slow. Yeah. So I realized that 1 year ago, exactly 1 year ago, I actually gave a thyroid lecture for Sunway Medical Center, and it was Tan Sulin, Salini, Saline Tan Sulin, who actually asked me to give it, and I got some slides from there. If you remember, 1 year ago, I don't know how many of you were at that. I gave a talk on hyperthyroidism. Okay. So I thought, yeah, you know, 1 year ago, give the hyperthyroid talk. So basically, cannot give again lah. You know, it comes down to something else, right? So now, July 2021, I'm going to give a talk on, right, what is the diagnosis? Just looking at this picture, you know what, this is a thyroid talk, okay? And
Okay.
you got A and B. I
Spot
think
diagnosis.
this is a spot diagnosis. Even cardiologists can make this diagnosis.
Okay.
Yeah, can or not, cardiologist? You can make or
Can.
not? Can,
Dry, thick skin.
dry thick skin. Very good. Very good. So if you made the same diagnosis as Dr. Betty Tay, dry thick skin, okay, I'll leave a link for you to link to her makeup tutorial that she has on Beating Hearts. Okay. Yeah, you can link to the makeup tutorial, and basically before makeup is A and after makeup is B. Okay. All right. She will go through with you in depth how to do it. No lah, Betty Tay, that is not the diagnosis. The diagnosis is obviously hyperspectaclesism. I mean, just look at those spectacles, right? Don't you think those are the best spectacles you've ever seen? The biggest spectacles you've ever seen in the whole wide world? They're goggles. No lah. Obviously, this is a lady who has, is a classic picture lah that you get from all your endocrine textbooks, okay? She has hypothyroidism. She looks depressed. She looks like, you know.
Can we use the word sallow?
No, sallow is not the classic
Really, right?
sort of
But, yeah.
appearance. Yeah, you can say sallow, I suppose, but it's not the classic word associated with hypothyroidism lah. Yeah, but okay lah. I mean, I guess it's just a word. You can use it how you like. But you can see that B is after she's been treated with thyroxine. So I'm going to assume that all of you are able to make this kind of diagnosis. All of you are able to sort of know the basics of hypothyroidism, how to basically diagnose it, that you need to treat with levothyroxine, and that basically after treating, patients will thank you a lot because they'll be brand new. Okay, so just a little bit of tips and tricks. And I'm going to do it through like how I did it last year, just run through some cases and make a few points with the cases lah. These are all semi-real cases. I can't remember the details exactly. I can't remember the names exactly, but it's just the salient points I remember from meeting different patients over the years. Okay, so this is a lady who's self-referred. She came to me complaining primarily of fatigue, weight gain. Are you a doctor? I exercise 7 days a week, 24 hours a day. I still get weight gain, and I'm always tired all the time. And I'm moody, I'm depressed, etc. Okay. So of course, when you tag fatigue and weight gain and you ask Dr. Google, okay, one of the diagnoses is obviously hypothyroidism. And then, one of the problems with Sunway Medical Center outside my clinic, I have an article on hypothyroidism. Okay, and then she sat in front of my clinic reading this article, I think. And then she came in and then she said, yeah, everything you said, everything that you this one, I have got it. Okay, I have got fatigue, weight gain, all the whole kind of thing. These are your textbook symptoms of hypothyroidism. And I think most of us have gone through medical school are very aware of this. But the problem is I get these exact symptoms. Few days ago when I paid my income tax, I got fatigue, I got weight gain, I got forgetfulness,
How do
I was
you get weight gain?
constipated. Yeah,
Your
because
stomach is like empty.
I paid my income tax and I felt like this, I tell you.
Poor libido,
I
I
don't
can
normally get
understand.
menses also, I got menorrhagia, I tell you, right? Losing blood. Okay, so yeah. And then, some of the textbook signs of hypothyroidism, okay, Sanjeev Mahadeva, okay, University of Malaya, professor of medicine, right, once called me up and said, I want you to take over this patient, right? This patient is quite frankly hypothyroid. I said, okay, what's the TFT? I don't need the TFT. I know that this patient is hypothyroid. I got the delayed reflexes. I got the dry skin. I got the goiter, etc. I will tear up these are his exact words. I will tear up my MRCP if this lady is not hypothyroid. And you guess what? That lady was not hypothyroid. Okay. So yeah, the point I'm trying to make is when patients come and give you all these signs and symptoms, they're fairly common. The fatigue, the weight gain, cold intolerance, etc. Okay. So at the end of the day, you do need to trust only the black and white. Okay. I get people calling me up. I get professors of gynecology calling me up saying that, oh, my daughter, she's losing hair. My daughter, she's like basically fatigued all the time. I talk to her and she's falling asleep and she's obese, etc. Okay, I think she needs levothyroxine, and then I tell them all to go and get thyroid function test done, because that is essentially what clinches the diagnosis. Okay. So lesson number one is, you always need the TFTs, okay? And it needs to be black and white. Now, so, did the TFTs for this lady, free T4 is in the normal range, okay? But the more important one than that would be a TSH, okay? Now, looking at the TSH, 5.41, and that is the normal range for Sunway Medical Center. What do you think I diagnosed this lady with? Right? Is she frankly hypothyroid? Your TSH is raised, your free T4 is okay. Do you need to do any further tests? Do you want to give her levothyroxine? What do you think is the diagnosis, Petite?
Difficult one, no?
Difficult one,
Yeah.
So
I think still treat her as hypothyroid.
Okay, this is subclinical hypothyroidism because the TSH is raised, although the T4 is within the normal range. Okay. Some people will go on and investigate further. They will look for a TPO, blah, blah, blah. But you see, at the end of the day, right, Mrs. Sao Chokeng, okay, complains of heat intolerance. Now, heat intolerance is atypical for hypothyroidism. Yeah. Hot flushes, insomnia at night, cannot sleep at night because of this heat intolerance. Okay, so I explained to her that look, of course you're fatigued if you can't sleep at night, and weight gain can be from multiple different causes. But the classic for hypothyroidism is actually cold intolerance. And what you need to do is, as you see more and more thyroid patients, you realize that subclinical hypothyroidism like this, well, sometimes it is good to actually treat. Sometimes you have certain times when you want to treat, especially if the patient is symptomatic, you want to give a trial of treatment. But it's also important to recognize the correct diagnosis, which I thought she was in the climacteric, she was perimenopausal. So inquiring about it, yeah, I mean, her menses, one of the things I didn't give the clue here is that she did have irregular menses. And I said that probably you would do better considering hormone replacement therapy, considering some estrogen. And I think that will probably would have solved her symptoms more so than giving her a little bit of thyroxine. Okay, now this level of TSH is slightly above the normal range. If your normal range is 5 and you got 5.4, okay, it ain't going to give you all these massive kind of like symptoms lah. You know, it's not going to give you that degree of symptoms, but menopause will. So what I'm trying to say is that yes, okay, you don't trust the symptoms. You have to look at the TFTs, but even with the TFTs, you do have to look back at the symptoms and kind of make a clinical judgment. You kind of say, now, if of course she had a massive TSH, her TSH was 10 times what I'm showing you, it was 50 or 54, right? Then definitely you would treat lah. Okay, but yeah, you know, taking everything into account, the heat intolerance was the kind of thing, and her age, right? And her name. So yeah, so I gave her some HRT, and I think she felt better after that. Okay, so that's lesson 1. Case number 2. Stop me at any time if you want to ask questions. Like last time, right, when I did these Betty Tay talks, I just talk and talk and talk and talk and talk. Then I kind of realized that she wants me to talk and stop and then yeah, give some cases. Anyway, case number 2, 76-year-old male. He's completely asymptomatic. He is on the following medications, all from government hospital, right? Perindopril 8 milligrams OD is very KKM. Yeah. Okay, so some routine blood tests were done. You know, children go and drag their parents for some wellness checkup in addition to what's being done at the KKM side. Okay, and he has a free T4 of 6.7 picomoles per liter. Okay, so importantly, you need to know what is the TSH, and he has a massive TSH. You don't even know the exact amount. Okay, but it's above 100. I didn't give you the normal range here. You know the normal range in Sunway is 0.35 to 4.9. TSH is super, super high. Okay. This is his weight. He's 76 kilograms. He's of average height, you know, about my kind of height, 1.76 centimeters or something like that. So my question would be, how much thyroxine would you give, given that he's so fulminantly hypothyroid? Now, this is another thing. You know, some people who gradually become more and more hypothyroid, like this gentleman, sometimes they can be very asymptomatic, you know, and that's the thing about it, you know, the TFTs do not always correlate with your symptoms, right? You can have patients like this, where it's like so fulminantly hypothyroid. The TSH tells you he's been hypothyroid for some time. Okay, the 3T4 is low, and you would have thought that he would have been complaining of lethargy, fatigue, and everything, but no, you know, he's completely asymptomatic. Okay, but he's massively, massively hypothyroid. So what dose of levothyroxine would you actually give? Would you give 25? Would you give 50? Would you give 100? Or would you give, I don't know, MCG?
Okay, maybe give them time to reply, answer. Okay, come guys. Let's see what your answer. I think I know.
Okay. Caroline Gunn, it's time for you to ACTS X.
Cause is 100 milligram. Sorry, who is that?
Caroline. That is
Caroline.
That is the one who will shoot you. The gun.
Hi, Caroline.
Hi.
Okay, what do you say? I didn't catch you just now.
No. Alex has called out my name. He used to help me in my.
He used to help you.
I help everybody. Now I'm helping tebet TBT.
Okay, so most people say 25.
Yep. Okay. So because they basically get it, all right, they basically get a few things. That one, this is an elderly gentleman. So you don't look at somebody who's massively hypothyroid and sort of say, oh my God, I need to give him like a super high dose straight away. Okay. You don't look at somebody and sort of say, okay, they are 76 kilograms. Okay. And the normal formula that most people apply would be 1.6 micrograms per kilogram. Okay, so if you have a 60 kilogram individual, 60 times 1.6, okay, would give you roughly about 90 something micrograms or 100 micrograms here. But again, you need to have clinical correlation. If somebody is on, you can see my pointer, aspirin plus clopidogrel plus trimetazidine, okay, and you look at his name, right? What does that spell to you? You know, that this guy has got
Underlying heart disease.
yeah, and probably he's in the last 12 months undergone some kind of procedure. Okay, so some of you will realize that if you give somebody something and they are not used to having a faster heart rate, right? One of the effects of levothyroxine will be to normalize bradycardia. So bradycardia in an ischemic heart tends to be protective. In fact, he's been given bisoprolol. But once you normalize the heart rate of somebody, okay, if you go from somebody who's very used to 50 BPM and then you raise them up to 80, 90 BPM because you gave them levothyroxine 100, you might induce ischemia. Now, some of you would also argue and sort of say, well, if he's already been stented, somebody's giving him dual antiplatelet, he's already been stented, should be okay. That's fine. That's fine. But he's asymptomatic, what are you rushing for? You know, and he's 76. Most importantly, he's an elderly individual. Okay, so you got time, right? It's different if this guy was, you know, none of you are endocrinologists, I think, okay. But if this guy was admitted with a hypothyroid coma, he's in mixed edema coma, he has a core temperature of 33 degrees Celsius, you know, he has a heart rate of 30, then that's different. Then that is under that kind of management I have to do. Okay? But if you have time, he's an asymptomatic guy. Okay, he has this background of ischemic heart disease. He's being treated for the ischemic heart disease. Okay, and he's elderly, right? You take your time. Honestly, you take your time. And so what I'm going to show you next would be the CPG for thyroid disorders. I'm sure many of you have read this word for word from front to back, cover to cover, right? 2019 MOH CPG.
Can I ask one question first?
Sure.
For previous patient, okay, if the patient came in a hypothyroid with, let's say, a heart rate that is low, would it be necessary to take off his bisoprolol?
I would take it off.
Yeah, I would take it off also.
Yeah, I would take it off. Yeah, I completely agree. I would take off his bisoprolol, his Corolan, or yeah, whatever lah. Yeah, so, yeah.
Okay.
So yeah, but he's asymptomatic. He's well, and so you know you do have to be careful in older populations when you start. You start gradually. So I would have started 25. Take my time, okay, and then just increase it every once a month or so, something like that. Okay, and the other thing is that if you talk to a lot of our geriatricians, they are even more easygoing about it. Okay, because they will realize that having the side effects of levothyroxine, right? These people going into AF easily, these people having fractures easily, is actually going to be worse than just leaving them as being slow and asymptomatic. Okay, so sometimes you know they'll come with a TSH of 8, right? So the normal range is up to 5, 4.9. Sometimes you talk to Philip Poy, the geriatrician, and he looks at a TSH of 8 also, he'll just sort of shrug his shoulders and say, that's fine. Okay. They don't go too heavy-handed on elderly individuals. Okay, but it's not just elderly individuals. I put in a bit of ischemic heart disease there so that, you know, there's that realization you don't want people's heart rate to suddenly jump too much if they've got sort of underlying issues there lah. Yeah, so that's for this particular gentleman, and you know, you can slowly read, but basically the point is that you want to be very low and slow with this guy. Just start at 25 and then gradually up titrate. You don't have to get it to super, you know, normal. You leave him at 6 or 7 or 8 or so, the geriatricians would say is like acceptable. Okay. Yeah. Okay, so if no further questions, move on to case number 3. Miss Annie Mia. Okay. Annie Mia, 38 years old, admitted for severe menorrhagia. Okay, it was like blood just flowing and flowing and flowing, flowing. Okay, and of course, a good gynecologist would also recognize that one of the causes would be this hypothyroidism. Okay, and so therefore, you know, in addition to the routine blood test, the TFTs were also done. Okay, so again, frankly, hypothyroid, free T4 is beneath the detectable limit.
Hypothyroid causes menorrhagia?
Yeah, it's associated with menorrhagia. And hyperthyroid, the opposite, is associated with oligoamenorrhea. Now, hypothyroidism sometimes can be associated with oligoamenorrhea if you have an individual who's extremely obese and has got associated PCOS, etc. But the classic association for thyroid disorders is that when your T4 is low, it's associated with menorrhagia, heavy menses. When T4 is high, right, it's associated with oligoamenorrhea. Yeah.
And what is the rationale behind this?
The rationale behind this is because it's published in the Williams textbook of. No lah, I mean, that's just one of these things lah. Don't ask me the exact rationale, but I guess if you probably don't know lah. I don't know. You just don't line your uterus properly lor. Yeah. Okay, so that's what you get. So of course she was treated lah. I mean, obviously she was transfused. Okay, and obviously she was treated. She was referred to me. I started on thyroxine. Okay, she was also given oral contraceptives at the age of 38 to help to regularize her menses. Of course, the tranexamic acid is there to also help with that. And of course, she was also in a lot of pain. She had some low abdominal uterine pain. She's given a bit of Ponstan as well. Okay, so a lot of the cases that I give are really easy lah, because you know the thing about hypothyroidism is I really do think that this is something that can be managed as an outpatient. Can be managed at the primary care level. Okay, and to be quite honest, after diagnosing, after treating them for a few months, and I realized that they are stable. Okay, TFT very normal already, taking the thyroxine very well. I usually either discharge them or tell them come back only once a year, right? I usually write a letter, in fact, to the GP and sort of say that, okay, you guys can take over now. Or I tell them, look, you know, you just come once a year lah. Of course, you do have some of these patients who sort of say, you know, no lah, I want to see you every 3 months, every 6 months, fine, that's your choice. But otherwise, you know, you can just come once a year, it should be okay. But one of the things is, do you need to check her TFTs very often or not? How often would you check it after starting levothyroxine? Would it be 1 day, 1 week, 1 month, or 1 year? Okay. 3 months, 6 months?
Let's say 6 months. Okay. Nimala said 3 months. Yi Kwang said 3 months. Sharif said 3 months.
Yeah. Okay, so there was a question there by sort of Dr. C.H. Cheng. So T4 so low, why TSH so high, why T4 can't go up? Okay, so this is just very fulminant and overt hypothyroidism lah, right? It does occur very once in a while. So that's the whole thing about it, right? Your TSH will be super sensitive. And I think you will see sometimes, you know, I do remember with some of these younger patients, I've seen things like thyroid atrophy and things like that, you know. It could be congenital hypothyroidism, although usually they will be a lot more severe than this one. But yeah, sometimes you do get these kind of TFTs. No, usually you would expect them to normalize between 1 to 2 months. So you don't check the TFTs on a weekly basis because you will be bengang, patient will be bengang, you will be bengang. You explain to your patients that it will take about between 1 to 2 months, between 4 to 8 weeks to normalize. And I wouldn't drag it out further than that because the thing about levothyroxine is that every individual's ability to absorb is slightly different. The brands of thyroxine also have different binders and fillers and will result in slightly different absorptions, etc. Okay, and so if you allow it to go on for too long, you know, if you sort of say 6 months only, then you come back and follow up, you may end up with a hyperthyroid individual, or you may end up with a suboptimally treated individual who's still hypothyroid. Okay, so I would say, you know, if you can, I mean, if you work in KKM and your clinics are tight, etc., it's different lah. But the ideal situation, you know, I normally bring them back after 1 month. Okay, so that is not just me saying it. Okay, you can actually see here again the CPG. Serum TSH should be reassessed 4 to 8 weeks and after any dose adjustments, including your first dose. Okay. Now, full replacement, again, 1.6 micrograms per kilograms when the TSH is markedly elevated. Okay, if it is milder, you can consider lower doses. That is true. And again, if it's an older individual, got ischemic heart disease individual, you could also sort of you should start with lower doses. Okay, so yeah. Okay, so got few more questions. Lady with hypothyroidism pregnant, CH Ng again. I will come to that. Okay, I will come to that. Oh, it was Core just now who was asking the question about TSH. Okay, now very important when you give somebody levothyroxine, there are a few things that I normally run through. What advice would you give about taking the levothyroxine 100 micrograms? A, you must take. B, you must take in the morning. C, you must take minimum half an hour before food. Or D, all of the above, right? So this is a platform that teaches you exam strategy as well. And if you're given the choice of all the above, usually the answer is all of the above. Okay, so take in the morning. Oh,
Take in the morning?
Super long question. I'll come back to the question later. Detrans BK
Yes.
Chong, right? Okay. Yeah, so it's actually all of the above lah. Petite. Okay?
Yes, but why must take in the morning?
Okay, that's just my preference. Okay, I'll tell you why. Let's go to the next slide.
Okay.
Yeah, okay, hang on. Okay, so the problem with levothyroxine is that its absorptibility is actually poor and it has to be taken on an empty stomach. Okay, now the CPG here itself says 1 hour before breakfast. Okay, but if you take it at bedtime, at least 3 hours after the last meal of the day. And the thing is, if you take levothyroxine together with food, so I explain to all my patients, okay, that you need to take this. In some cases, I need to stress to them that this is a for the rest of your life kind of treatment. You know, some of them think that, oh, you know, I got Tai Keng Pao, I take this medicine for 3 months and I'm healed. But yeah, in many cases, they are not. So I also stress to them, okay, I am not so strict as the CPG lah. I say half an hour because I do realize that 1 hour can be quite difficult for some individuals, especially individuals who are working. You know, they wake up, they have to get ready and everything. They have that half an hour and then they have to eat already and leave the house. So what I say is that, you know, you put it right next to your bedside. As soon as you wake up, you glut it with some water. Then only you go and brush your teeth and do your other stuff, change your clothes, go and have a shower. Then after half an hour, only you take your levothyroxine, because if you take it with food, you take it with your coffee, with your milk, with your roti canai, with your cha bee hoon, or whatever it is going to have impaired absorption, okay, and it will be a bit wasted. So therefore, yeah, you do it. Now, why early in the morning? Why breakfast? Because there's actually a small study that was done at UKM, and the people who wrote the CPG are aware of this, where they actually tried to do this 3 hours after the last meal of the day business. Okay. The 3 hours after the last meal of the day was based on a Belgian study, I believe, where they said it's just as effective as before breakfast. Okay. But we are Malaysians. And you know, this small UKM study that was done by Shamila Sunita, what she found was that nighttime taking of levothyroxine was a disaster. You know why? Because Malaysians, 3 hours after the last meal of the day does not exist one. You know, people eat until 2 a.m. People wake up in the middle of the night to watch World Cup and football. All right. So it, to me as a Malaysian doctor, I don't give them that 3 hours after the last meal of the day advice. I just go straight for, you take it first thing in the morning when you wake up. You have the thyroxine pill next to your bed. You wake up already, you swallow the water together with it. Then you go and shower. Then you go and brush your teeth. Then you go and comb your hair. Then you go and get changed. And hopefully by then half an hour has passed. Okay, and then you can have your breakfast. Yeah, the longer you can leave it, the better. Okay, so if you want to go and do Tai Chi first before you take your breakfast, that's fine. Okay, but you must do it on an empty stomach, and advising them to do it in the night I don't think I mean, it's not just I don't think, like, Shamila did the study in UKM and found that it was a problem. It was a problem because people in Malaysia like to snack at night. Belgians somehow don't snack at night like we do, but a lot of people snack at night in Malaysia, just like, I feel a bit what, go and take this and take that, or in fact take a full meal. Okay, so yeah, that's why it's all of the above. Okay, is there any other advice that you would give about taking the levothyroxine? Apart from you must take it for life. Okay, you must take it early in the morning, half an hour before your breakfast. Don't mix it with your breakfast. Okay. Is there any other advice that she should be given? Should she stand on one leg and hop while taking it? Should she, I don't know.
Seated. Esther said seated. She should be seated.
Seated? Wow. No.
Anyone
I'm not sure.
else?
Ha 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 ha. Okay. Okay. So again, I don't give you the direct clues. I want to say ischemic heart disease, but I just say aspirin and clopidogrel, right? Now, what you do have to recognize here is that we do have lots of patients who love taking vitamins. Okay, you ask them to take a statin, they think they're going to die. They think they're going to get Alzheimer's. Okay, they think that their muscles are going to melt and there'll be skin and bones. But if you ask them to take QQ10, milk thistle, red rice yeast, then that's all okay. All right. So what I was showing you here is that because of her anemia from the severe menorrhagia, she was transfused. She was also given sangobion, right, by the gynae. So sangobion, of course, hematinic, contains large amounts of iron. And one of the things which we say when we say don't take it together with food is that, of course, you will have iron in certain foods. You will have calcium in certain foods. And taking milk together with levothyroxine is bad because it will bind your levothyroxine. Taking iron with levothyroxine also is bad because it will bind. Okay. So this is a fairly old and classic study to sort of say that ferrous sulfate, ferrous fumarate, ferrous whatever, okay, will actually affect the way that your thyroxine absorbs, and so therefore you will become, having a high TSH level, i.e., more hypothyroid if you took your thyroxine together with iron tablets, or this is the same case for calcium as well. And again, the CPG comes out with this, calcium salts, okay, ferrous sulfate, right, phosphate binders, proton pump inhibitors, okay, oral bisphosphonates. These are fairly common. Patients taking omeprazole, patients taking ranitidine. Well, no more ranitidine, but the same concept is there. Yeah. So what you need to also say is that if possible, right, you push your vitamins towards the lunch or the evening. Okay, you take it at least 3 or 4 hours later, so that breakfasting is half an hour. But if possible, okay, you push all the others 3 or 4 hours later. One of the things here is espresso coffee as well. So yeah, I mean, if they can't, if they must have an espresso in the morning, okay, they just need to do it regularly, and then you have to titrate your dose of levothyroxine, understanding that these things will affect it. Soya beans will affect it as well. Okay, so yeah, this is not you don't have to remember this every single thing, right? There's no exam on this, but you do need to remember this concept where when you take the levothyroxine, right, okay, breakfast half an hour, vitamins if you can take it at lunch or beyond, okay, don't take it in the morning after half an hour if possible. Now if there is no choice, if they kind of say that I must take my proton pump inhibitor, if I don't take my Nexium, my whole day I got dyspepsia, etc., you have no choice, but they take it regularly and you have to up the dose of levothyroxine to more. So where you think that 100 micrograms was enough, you'd probably end up giving 150, 200, simply because of the PPI. Okay, so it can be overcome. It's just that it's a lot less well absorbed. Okay, so this is things that you need to tell this lady about. Miss Anemia is taking what do you call this, Sangobion. Okay, so again, levothyroxine may need to be adjusted. Another thing is, of course, she's on Mercilon. Yeah. So Mercilon is what? Estrogen. And estrogens also is another thing. Okay. So this is not to do with diet anymore, but it does affect thyroxine binding. Yeah. So when when it kind of like kacau the way that your TBG acts, because it can cross react. Okay, so in the gut, iron and thyroxine fight for entry into the bloodstream. Okay, me first. No, 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 no. You go to the back of the queue, thyroxine. Okay, I don't care if you get pooped out. Right, iron wants to go in first. But once you get into the bloodstream, then if you are taking androgens, testosterone, then if you're taking estrogens, okay, you do have to realize that there is some fighting there as well to bind to globulin, and you do need to adjust. Now, of course, you will come to a sort of not steady state, but you will come to a balance after a while, because as they take the estrogen regularly or they take the androgen regularly, you have to dose titrate. But just be aware that when you're newly starting an estrogen, for example, hormone replacement therapy, OCP, okay, you will need to do a bit of dose adjustment for this. That adjustment is not as much in the magnitude as the with iron and all that lah, but just something else you can be aware of. I don't know if you guys will be seeing cancer patients on TKIs, right? Tyrosine kinase inhibitors. Okay, but that is also another thing which is now newly recognized to interfere with thyroxine. Okay, and then of course there's your classic interferes with everything one lah, this phenytoin lah, rifampicin lah. Okay, so all these sort of alter the hepatic metabolism. Yeah. Okay, so she's on Mercilon and Sangobion. So therefore, these are things that you need to be aware of. The Sangobion you can do something about. The Mercilon, I mean, you just have to adjust lah. So 2 months later, free T4 is 13, okay, within the normal range. TSH, however, is still high. It has come down a lot though. Okay, it has come down by from 100 to 12.5 2 months later. Okay, so this is good. She has improved. Okay, what do you want to tell her? What do you want? Is there anything you want to explore with her? It's 2 months later already. Do you want to maybe increase the dose of thyroxine? Do you want to leave it the same? What do you think? Would you increase the dose because you still haven't got a normal TSH level? Or would you actually keep it the same, wait for another 2 months maybe, or what? What would you do?
And what would you do?
What would you do? Hmm?
Anyone? What would you do? Esther,
You would log off and go to sleep.
wait for a few months. Continue monitor at the same dose. Check
Dr.
whether
Ken Pua, check whether the patient is compliant. Yeah, very good. Okay. So that would be the automatic thing that you also need to do lah. Okay. So when you have 38-year-olds who are not used to regular medications, right? 38-year-olds are not like your 75-year-olds lah. They are very, very structured when it comes to their medications. And it's only been 2 months of needing this regular medication. One of the issues would be compliance. Okay, you can make an argument if, let's say, Miss Anemia tells you that, okay, fine, I have been 100% compliant. Okay, then you might sort of say, oh, well, it did come all the way down from 100. Maybe I should just wait a little bit more. But usually it would have normalized by now lah. But yeah, Dr. Kempua, that would be exactly what I would have done lah. So yeah, she says that I always forget to take on weekends because I wake up late. Okay, familiar thing for some people, right? Weekdays I have to go to work, right? Of course, this is not during the MCO lah, but everyone's working from home. But right, weekdays I wake up because I have to go to work. But Saturday and Sunday I don't need to go to work, so I wake up at 10 a.m. Okay, so and then I forgot to take. What can you do in this kind of situation where there are these particular days where they're waking up late or they forgot to take? Is there any particular advice that can be given? Can they ganti balik, or can they, do something about it? Take it at night? Anybody have any clues?
would it make a difference if they take higher dose 5 days a week?
That is actually the answer.
Oh,
That is actually the answer.
I'm so
That is
clever.
correct. You are so clever. Yeah. So what happens is levothyroxine has a very long half-life. It's about a week. Yeah. So you need to understand that the accounts are settled on a weekly basis. And so if you look at the notes of some endocrinologists, they don't actually write that the patient is on 100 micrograms once daily. They will actually write that the patient is on 700 micrograms a week, right? So when you miss a dose on one day, like let's say, the patient woke up on Wednesday, right? Discovered that there was a massive leak from the ceiling, and so therefore went into full panic, forgot to take the thing, called the plumber, fixed the thing. Then the next morning woke up, realized that yesterday didn't take. It's not the end of the world. What I classically teach them is to actually say you can take yesterday's dose, the Wednesday dose, on your Thursday. So on that Thursday, you take 200 instead of 100, and you can ganti, and you can do this for up to a week. So there are the guidance from the CPG also says that in certain patients, psychiatric patients where it's difficult for them to receive their medicine, etc., studies have been done to sort of say that, look, it's not ideal for compliance, but if you gave them 700 one shot once a week, right, they will still be okay. If you just gave the thyroxine once a week, the full dose, right, you settle that account rather than on a daily basis, you do it once a week, it's actually okay. I don't encourage doing that like once a week. You just take the 700. I still prefer my patients to take it sort of on a more daily, regular basis lah. But if Saturday and Sunday cannot, right? What I would actually say is that yeah, you distribute everything back into the 5 days, exactly like you say, Betty. Okay, so if you count, yeah, you need to split the 200 that was not taken into that 5 days. Okay, so you end up maybe taking 125 a day. Okay, you might be a bit higher, right? Or for example, you can say something like, okay, then Thursday and Friday you take 200. Yeah. So you have pulled the Saturday's dose to Thursday, you've pulled the Sunday's dose to Friday, for example. Okay, but whatever it is, you just make it up to 700 in that 1 week. Okay, that also works because of thyroxine's long half-life, and so therefore when I titrate thyroxine, sometimes I titrate it according to a weekly kind of basis. And that's why sometimes if you see a specialist, our prescriptions are a bit weird. We'll say that take levothyroxine 50 micrograms from Monday to Thursday, then from Friday, Saturday, and Sunday, you take 100 micrograms, right? Because basically what we understand is that it's the weekly dose that matters. Okay, so when you get situations like this, there's always you can do one thing. You forgot today's dose, tomorrow you ganti with 2 tablets. Okay. Likewise, another scenario would be, I realize at lunchtime, okay, that I forgot to take. Should I therefore take it at lunchtime or not? Okay. Again, I trust Malaysians to have very good appetites and eat a lot. So I always tell them, don't worry lah, you miss it. The next morning you take it on an empty stomach, 2 tablets instead of 1. You ganti back the next day rather than take it at lunch where I fear that it may not be absorbed because you're going to eat char kway teow. The other thing, of course, is the other question is, if I can ganti balik, how many days can I ganti balik? And of course, the answer is 1 week lah. But I always try and tell them that, look, you don't go and do this ganti balik trick on me, okay? Because you will then, I don't want you to lapse into a sort of like, okay, I just take it once a week and then like completely forgot the entire week. So yeah, this is another sort of lesson. Yeah, okay.
Okay, I found out why hypothyroidism can cause menorrhagia. I sent the explanation because.
Okay, thank you very much.
Yes. Okay. So 4 months later, anemia. Change name or not? Now that she's not anemic anymore. Never change.
That one, she has to make an appointment with the IC department. Yeah.
GPA. Is it what? Jabatan Penghematan Awam. What?
Pendaftaran Malaysia. Jabatan Pendaftaran. Yeah. Okay. So now you have a situation where pre-T4 is high, 21. TSH is normal, 2.5. So, are you going to cut back on the levothyroxine? And by the way, all that Sangobion, all that Mercilon, all that all stopped already. Periods back to normal. Okay.
Okay, can I ask this question?
Sure.
If she's obese, do we need to cut back on the thyroxine? Can we allow her to lose some weight? Or
if you, Betty Tay, which medical school you come from? If you cut back, if you lower the dose of somebody's thyroxine, they will grow fatter.
Yeah, that's right. So do we, let's say now her T4 is 21. Okay, her TSH is normal. Some people will say, oh, it's time to cut back. I think let it be, especially if she's obese.
Yeah.
Wants to cut back already to 75, you see?
Yeah. Okay. No, so again, this is another little thing that I get lots of referrals for, and people worry about it. So the first thing that I would do in this situation is I would say that I would look at the blood test and I would say that you took your tablet and within 3 hours or 4 hours of taking your tablet, you did the blood test, right? Okay. because as much as we want to believe that our medications are perfect and distribute evenly, okay, they do get this slight spike in the first few hours after taking levothyroxine, where they can
Oh, I
have this
see.
transient high T4. So this is a classic endocrine exam question, you know, where baby endocrinologists want to become adult endocrinologists. They go and face all these Khalid Kadirs and Chan Siu Pengs and sit in the exam chair. You know, this is one of the classic questions that we are given. Not classic anymore because everyone knows this answer. But yeah, these kind of weird TFTs. So at the end of the day, you still follow the TSH. You must remember that normalization of the TSH is what you're chasing after, and that free T4 can be really, you know, can change a lot depending on certain things. Okay, can change a lot depending on even NSAIDs, for example, can affect free T4. Okay, but recent ingestion of thyroxine, 100 micrograms, can result in this kind of reading, but as long as your TSH is normal, then that is fine. Now, Betty Tay, the equivalent of your question would be to sort of say that if I have an obese individual who is euthyroid, his TFTs are completely normal, okay, would I give him levothyroxine so that he becomes a little bit hyperthyroid and lose weight? Yeah, you can. He will lose weight. If you make him thyrotoxic, he will lose weight, right? He has to be significantly thyrotoxic to lose the weight, okay? But at the same time, you will give him palpitations. At the same time, you'll give him tremor. At the same time, might tip him over into AF.
So if it's just marginally low, it won't work. Marginally high, the T4.
So there's this classic story you can Google it, right? Muhammad Ali, champion of the world. Okay, he was the champion heavyweight boxer of the world, and like many of these celebrities, he became famous, and when he became famous, he became fat. Okay, and he actually ended up trying to use levothyroxine back in the 60s at one point to lose weight so that when he went into his boxing match, right, he would be of a healthy weight lah. Okay, not of a healthy weight, but he would be at his target weight for that particular boxing match. Okay, and then the problem was he lost despite being lean and mean. And later on, when he was interviewed, you know, he wasn't told that it was because of thyroxine. He just swallowed whatever tablets he was given, but his coach was giving him thyroxine to achieve that weight. And the problem was he was tremulous. The problem was his coordination was off. The problem was his brain was in 10 places because he wasn't thinking straight during the match. So yeah, a lot of people theorized that it was probably because he was being given thyroxine. He was actually hyperthyroid. He managed to lose all that weight, managed to get into his boxing match, but he lost. Okay, he lost to Joe Frazier. So yeah, I mean, like many of these things that increase your metabolism, okay, you have to be careful with what you play with. Okay, there are many weight loss drugs there that work on this basis of increasing somebody's metabolism. You can give somebody adrenaline, okay, and if you give them large amounts of adrenaline, yeah, they will probably burn more and they will probably lose weight. But at the same time, of course, you might give them AF. So you gotta be careful Betty Tay, doing this kind of thing. I know that there are some doctors who are non-diabetic take Zinc Duo to lose weight, right?
No,
and then they become interested in taking levothyroxine to lose weight as well, Betty Tay. Okay,
no, I've heard of doctors who are giving a concoction of drugs to the patients to lose weight, and this is practiced by, you know, a certain famous gynecologist.
Yeah, this happens everywhere you know. It's just like people who give steroids you know, you got fever, you got sore throat, you got headache, you got loss of appetite. Okay, I give you this magic pill called dexamethasone, everything will be fine, isn't it? So yeah, I mean, everything will be fine, but 1 year later, your patient has a moon face and a buffalo hump, right? So you can have famous doctors law doing famous things law, infamous things, but it just
Okay,
doesn't mean
let's
that
go on.
it's yeah, right. Yeah, so actually, but this is just to illustrate lah, if you get weird things like this, just look at the TSH. The TSH is within range, you're actually fine. 6 months later, TSH 3.5, free T4 13.7. Both of them are actually in range. Okay, so congratulations. Pat her on the back, pat yourself on the back. Okay, anything else? It's not only recently admitted for severe menorrhagia, it's been 6 months already, lah. So it's 6 months after severe menorrhagia. Now she tells you this. What goes through your mind?
She's pregnant.
Yeah, very good. Okay, very good. If she's pregnant, does this change your management at all? Okay, because there was a question earlier on by what? Dieter BK Chong.
The trends.
Yeah.
Oh my God.
Have you watched Army of the Dead? The safecracker is called Dieter.
No, I'm not.
There's Army of the Thieves as well. Okay. Okay. So when you have a patient who is pregnant and on levothyroxine, it's time for you to refer to me. Okay, because this one you really don't have much time to make sure she's okay. In pregnancy, you only have 9 months. You can't be saying, okay lah, come back in 3 months lah, okay lah, come back in 6 months. Okay, that's like 1/3, 2/3 of the pregnancy already. But just one thing, because many of you will, if you are in primary care, you will come across scenarios like this. When you have somebody who's pregnant, the automatic thing that you need to tell them is that they usually need to increase their levothyroxine almost straight away. Okay. The only caveat will be if they're already overtreated and they're frankly, they have low TSH and high free T4 because they've been taking too much, then that's not a good scenario. But the normal range for TSH, I'm sorry, I should have given that slide. I just, when I was preparing, I don't know why I forgot. I have this slide somewhere. The normal range for TSH in the first trimester of pregnancy, okay, should be less than 2.5. In fact, in every trimester of pregnancy, we try and keep the TSH to be less than 2.5. The normal adult range of up to 4.94 or whatever the lab you use is no longer applies. Once a patient is pregnant, we try and push that down to less than 2.5. Why? Because the studies have shown that if the TSH is less than 2.5, okay, if the TSH is more than 2.5, it does affect fetal
Development.
No, not fetal development. It does affect future IQ in
I see.
the newborn. Yeah. So in a way, neuronal development lah, I suppose. Okay. The normal range for TSH tends to take a dip even for normal women, right? The Egyptians used to slyly diagnose pregnancy. One of the recognized causes of goiter, according to ancient Egyptian medicine, was actually pregnancy, and they are quite correct. Okay, your thyroid does actually engorge, like many other things in your body when you are pregnant, and TSH can actually go down all the way to 0.1 and still be normal, especially if you have hyperemesis as well. One of the reasons is, of course, because TSH, LH, FSH, and HCG, right, all have a similar structure and a similar what they call alpha subunit. Okay, that's why when we measure HCG, we say beta HCG, right? Because the alpha part of the HCG is actually the same alpha part as TSH, is the same alpha part as LH, FSH, all that lah. Anyway, you don't need to know that, but basically, yeah, we want to bring the TSH to a little bit lower. And so the standard practice is to actually tell them to increase their levothyroxine dose once they confirm that they are pregnant. How much to increase by? Well, it's an agak kind of thing, right? But classically, what I would say is that for 1 or 2 extra days per week, you take an extra tablet. So what I would have done is for anemia, right? If she's confirmed to be pregnant, I would have, and I have this kind of TSH, I would have probably said, yeah, you increase to 800 micrograms per week, meaning that you continue with 100 from Monday to Saturday. On Sunday, you can take 2 tablets, please. Okay, so that would be the thing. Okay, and then you follow them up on a monthly basis and adjust accordingly lah. But that should be actually done by an endocrinologist. The rule of less than 2.5 should only apply to patients with hypothyroidism, not every pregnant woman. Okay, because the problem is when you replace somebody with levothyroxine externally, exogenously, as I've explained before, it's not a perfect thing, and we are using these arbitrary measurements. Okay, but we do have the data which shows that on patients taking levothyroxine, if you aim less than 2.5, your baby is going to come up more intelligent. We also have the data to sort of say that, look, if you have a normal woman who's not on levothyroxine and you do their TSH and it's 3.5, then just leave it alone. You don't have to give them thyroxine. It's perfectly normal. Thank you, Ken Pua, for that question. Okay, so yeah, this is, if they're pregnant, yeah, it's one of these scenarios, Arila, where you need to make sure that she's seeing an endocrinologist. Okay, so there are lots of questions that I can see. Thank you very much for just giving your attention to my short presentation. Let me open up the chat. So Ken Pua's question I have answered already. For patients who develop hypothyroidism secondary to radioiodine therapy, how often do we need to repeat TFT if they are clinically euthyroid? Okay, Dr. Haiza, the goal of RAI nowadays is not to achieve euthyroidism. When I counsel my patients for IRI, I say that we are purposely going to make you hypothyroid. Why? Because hypothyroidism, you give levothyroxine, okay, it's easily controllable. You don't have to titrate as much as, say, carbimazole. There are no side effects with the levothyroxine as opposed to, say, carbimazole with the liver, with agranulocytosis, etc. So we purposely make them hypothyroid, right? And when do we expect the radioactive iodine to make them hypothyroid? On average, about 6 months after the RAI, if enough RAI was given, okay, I counsel them that within 1 year, they will be hypothyroid. On average, about 6 months, but sometimes as early as 3 months, they become hypothyroid.
Okay, hold on for what? Sorry, can you just unshare your screen so that I can share the, okay, thank you so much.
Yeah, okay. So I have unshared oh my God, now we have hyper participants, 62. We started with 24. Okay. Yeah, so yeah, what I would do is if somebody has received RAI, okay, I would definitely follow up within a month of the RAI, okay, because classically they would still be on some form of anti-thyroid. Titrate the dose of the anti-thyroid accordingly. If they were frankly still very hyperthyroid, then of course you follow them a lot more closely lah. But if you are just waiting, if they are euthyroid and you're just waiting for them to become hypothyroid, I do the next one 3 months after the RAI, then 6 months after the RAI, and then at some point you need to diagnose the hypothyroidism and put them onto levothyroxine. Now, thyroid, Dr. Kaur, very active. You are a very active nodule, Dr. Kaur. Thyroiditis, why some become hyper, why some become hypo? Okay, it depends also on the stage of the thyroiditis. When it's very acute and there's large amounts of inflammation and cell destruction going on, okay, so your thyroid gland manufactures thyroxine, but guess what? It doesn't manufacture and then immediately ship it out, right? Some of it is still stored within your thyroid gland. So of course, if you have an inflamed thyroid gland and the cells are just being destroyed and you have release of thyroxine, suddenly you have release of thyroxine into the bloodstream, they are hyper. If, however, your thyroid gland has undergone all that destruction, okay, And so therefore the function of it, the cells which are left, are depleted or not depleted, not able to come up with enough thyroxine to maintain a normal T4 level, okay, then you'll be hypo. Okay, so thyroiditis, you just have to follow the TFTs. Okay.
Can we answer the trans BK Chong's question first? Because he posted
Below
it
knee
3
chong.
times.
Okay, let me try and find it. 20-year-old male, TSH is 6.5, T4 6.6, T4 is 15.8. Okay, no medical illness. Operation done before, no family of thyroid, no family history, clinically asymptomatic, COVID vaccination dose, second dose 3/5/21. Okay. How would you advise to manage this patient? In fact, the above TFT results was a repeated test done 3 weeks after the first test, which showed a higher TSH. Okay, so first of all, it's very good that you repeated the TFT and you didn't act on the first one, right? Okay, so what you have clearly here is a TSH which is slowly becoming higher, all right? It has gone from 4.9. You don't give the normal values for yours, but I'm going to assume that TSH is going to be high for your particular lab, right? There are some labs where the TSH cutoffs are actually, say, 3.5, like in UMMC. In Sunway, it's 4.9. And then, there are some other labs I've seen where it's 5.5. So, so you have a continually rising TSH, okay? And you have normal free T4 and normal free T3. What I would do in this young male who's clinically asymptomatic would be to monitor again one more time. This is a scenario where you have developing subclinical hypothyroidism. I wouldn't go in at the moment. If you suspect this is an effect of the COVID-19 vaccination, that this is somehow given him a thyroiditis and then he's hypothyroid, right? Okay. If he's asymptomatic, he has got no complaints, I'll just monitor for now, especially. Now, if at any time the TSH crosses 10, or if at any time the free T4 and the free T3 dip below normal levels, right, I would treat with levothyroxine. Okay. Now, this is a separate lecture on subclinical hypothyroidism, subclinical disease. It comes down to taking in both biochemical as well as clinical factors to make a decision whether or not you would treat, i.e. to give levothyroxine. Patient asymptomatic, I would back off from treatment. Patient symptomatic would like to try treatment, I would give. Okay. TSH is only slightly above, I would not give. TSH very highly above. So normal free T4, normal free T3, but you have a TSH of 50. Okay, that you have to treat. Okay, because the concept is in this particular gentleman, you have to think is, are they really going to slip into overt hypothyroidism? Is that what I'm seeing? Is it going to be that by the third time I repeat the TFT, the free T4, T3 has dropped, and the TSH would have gone much higher, and I would have to treat anyway? Okay, so time will tell. Okay, now you can get some clues about whether they will slip in. Right, one would be do an ultrasound. If you see that the ultrasound is normal, then you can wait. Right, if you see the ultrasound shows thyroiditis, for example, okay, then you know that this is going to be an ongoing process, and it's likely that maybe in a little bit in the future, okay, they may slip into overt hypothyroidism. You can do a anti-thyroid peroxidase antibody, which is for Hashimoto's thyroiditis. Okay, and if the TPO is positive, okay, you know that this is going to be somebody who will slowly slip into hypothyroidism at some point. So again, that okay, so yeah, so that is to BK's question. When should we take TPO antibodies in hypo patients? When they can afford it. Okay, so yeah, when TPO is classic for Hashimoto's thyroiditis, and with reference to an earlier question, why in sometimes thyroiditis you get hyper and hypo. Okay, if you have a patient where you where they're hyperthyroid to begin with, but you suspect that this is not Graves, right? They don't have the bulging eyes. They are sort of um, TFTs are slowly normalizing even without carbimazole, antithyroids, and you're afraid that they may slip into hypo, you can do a TPO. If it confirms that you have Hashimoto's, then you can explain that, you know, they may slip into hypo at some point. Does the TPO change your management? Absolutely no, right? Your dose of levothyroxine doesn't change with the TPO. It's a diagnostic thing to say that you have Hashimoto's, okay? And if you have Hashimoto's, it's potentially hereditary, okay, right? Autoimmune thyroiditis, you can get it down the family tree. That would be one thing that might change, but it doesn't actually change. If you have Hashimoto's, then maybe you can also tell them that, okay, this is not Graves. So I don't routinely do TPO in my patients, one, because it costs a lot more. I just track the TFTs.
Doctor
So, yeah.
H. Asks, is myxedema madness reversible?
Most myxedema things are reversible with the administration of levothyroxine, unless during that they've had some form of event, like for example they've had a acute coronary syndrome while you're treating them with thyroxine, and then they go into heart failure because of that. Then it's irreversible. If they've happened to have had a stroke when you're in the ICU, then of course that's
Error. Is there anyone who having error in scanning the code? Okay, yes, Bella? You having error? Okay, there is a question which says that have you answered the thyroid?
Yeah. So okay, yeah, Laili Hassan, you made a good point. That is true. So it comes back to the same thing. When you have subclinical hypo, right? The question is whether this is going to get worse or not. Okay. And if you have TPO antibodies, yeah, that's true. You have the antibody, it's likely you will have progressive disease. So yeah, thank you for pointing that out. I completely forgot about that. So that is one of the rules. Not rules, I would say. You discuss it with the patient. You can tell the patient, look, you have TPO positivity. This does mean that your today's TSH of 6 by next year will be a TSH of 7. The year after that could be a TSH of 8, and one fine day you could go into overt hypothyroidism. So I'm sorry I didn't include some cases on subclinical hypothyroidism here, but subclinical hypothyroidism, the key is that you want to know whether this is somebody who will progress and will slip into overt hypothyroidism, and you treat first. Okay, so yeah, TPO will give you a clue. Ultrasound also will give you a clue. TSH of above 10 is also a big factor to sort of say that you should treat. Other things in which I would treat in subclinical would be the presence of symptoms. If I was being pushed, if the patient sort of say that, you know, you do have some patients who TSH is 7.5, T4, T3 is normal, but they tell you that they're just so tired, you know, sleeping is a problem, blah, blah, blah. You treat and then sometimes they do get better with normalization of the TSH. So yeah, thank you for that.
Okay, if anyone has problem with scanning the QR code, please WhatsApp me at my number with your name, IC, and MMC number and email address. We will do it manually. Even ask if patient choose lifetime carbimazole treatment over radioactive iodine. Anything to look for?
No, except that except that lifetime carbimazole, you have to treat hyperthyroidism like a stray dog that you take into your house. Okay, that may not be the best example, but yeah, this is something that I would say. You take this stray animal, you put him in your house, you try to discipline him, you give it some love, you give it some carbimazole, okay, and you say, be under control. Don't simply bite people, okay? Don't simply go and scratch people.
Oi, how
all
can
right?
I got 6 stray dogs in my house?
Yeah, exactly. Perfect example then. Okay. But once in a while, it will relapse. And sometimes it's out of your control what causes the relapse. Yeah, Bella Tan. Okay. It will relapse. It's like me. You can't control me, you know. Sometimes I'll just relapse
Use
and
you,
make
don't
fun
use
of
my
you.
dogs.
Yeah. So it will relapse. Dengue fever can trigger a relapse. Motor vehicle accident can trigger a relapse. Okay. And when you catch that relapse, you will have to titrate the dose of carbimazole upwards to control the thyroid again. So you will temporarily need to up them to 30 milligrams or 20 milligrams or whatever it is. Then once that relapse calms down, you down titrate back again. Okay. All right. Patient needs to understand that lah. Radioactive iodine and thyroidectomy are definitive. You shoot the dog, you poison the dog, you
Oh my
radioactive the dog.
God, please.
This dog is never ever going to bite anybody ever again. So when you do a thyroidectomy, when you do an RAI, there's no they are inactive already. There's no more biting or anything. What you must realize with carbimazole, it's controlling, right? It will control the thing. There may be a chance of a relapse. When it relapses, you have to up your dose and you have to titrate your dose lah. Okay. But when you do RAI and when you do thyroidectomy, there is no need for you to control. In fact, you are in control because the control will now fall to levothyroxine. And levothyroxine, when you titrate it, it's exactly where you want it to be one, you know. It's not suddenly where, you know, the thyroid will decide that, oh, okay, I'm going to push some extra out or push some extra less. No more thyroid already, ma. Okay, so then the thyroxine will control the TFT. But you have to realize that when you use carbimazole long term, you're not in absolutely going to 100% control the thyroid all the time. There may be occasions where you get exacerbations or relapses lah. Yeah.
Okay, not a good analogy, but then
Yeah.
the talk
But
was,
that's the one I use for all my patients. I tell them this is an animal.
oh my
Okay. You
God.
have it under control with the carbimazole. At some point, it might go out of control. So the other way to do it is, yeah, to kill it lah.
Okay, I think we won't take any more questions.
Because of that.
Okay, got some more questions. Laili Hassan asked, in CPG, one of the indications to screen thyroid in pregnancy is age more than 30. Why is that?
It's just that it's a bit more common and it's not something that you want to miss out lah, you know, having a fetus born,
With low
having a
IQ.
fetus with low IQ, having a fetus with hyperthyroidism, going through pregnancy with hyperthyroidism, you know, having a miscarriage, yeah.
Okay, thank you very much, everybody. This is the end of the 2-month CPD session. The first month was with Beacon and the second month was with Sunway. Next week, we have something light. We have a switching of career talk with Jason Leong, the comedian. How to change from medicine to being a stand-up comic. So I see you guys then. Bye. Bye, Alex. See you.
See
Thank you
you.
so much. Bye.